Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
So we focused basically on two major abstracts from ASH this year, one of which was a late-breaking abstract called the ASPEN study, which was zanubrutinib versus ibrutinib in treatment of CLL, which showed a progression-free survival benefit for zanubrutinib and actually led to a recent FDA approval for zanubrutinib for treatment of CLL. And we also talked about the TRIANGLE study, which had been presented at the plenary, looking at whether or not we should incorporate ibrutinib into our standard of care therapy for mantle cell lymphoma, and perhaps if by doing that we could potentially avoid autologous transplant for consolidation for patients with mantle cell. I think the zanubrutinib one is kind of practice affirming. I think that most of us have kind of moved to the newer BTK inhibitors for many indications, not just CLL. So it is nice to have another option and to have that approval for CLL. For TRIANGLE, for mantle cell, I think we're starting to see challenges in the paradigm for mantle cell lymphoma. For years it was induction therapy, autologous transplant. And I think it's good that as we get newer agents like BTK inhibitors, we're taking a step back and going, okay, where do we incorporate them? And if we incorporate these agents, do we still need some of these other therapies like autologous transplant? Some other studies have tried to look at, if we're using a BTK inhibitor, for example, do we still need high-dose cytarabine? Because something like being admitted for high-dose cytarabine or autologous transplant, that's a really big deal for the patient. So taking those things potentially out of the treatment algorithm could be huge for the patients. So I think we're going to see, in general, I feel like across the board, we're just seeing less and less traditional cytotoxic chemotherapy. When I talked about TRIANGLE, one of the things I mentioned was they used a relatively intensive chemotherapy, alternating DHAP with R-CHOP. Many of us use something called the Nordic regimen, alternating high-dose Ara-C with R-CHOP. And again, those are kind of a big deal, especially the Ara-C containing regimens. So could we use less chemotherapy, less intensive chemotherapy? No chemotherapy if we kind of do thoughtful combinations. And I think that as we get more small molecules, bispecific antibodies, cellular therapies, I think we're just going to see less and less cytotoxic chemotherapy really across the board for all the diseases we treat. I guess I want to highlight some of what we have going on at UC Irvine right now. So we now have, in addition to a number of cellular therapies on clinical trials, we do now have access to standard of care CAR T cells for diffuse large B-cell lymphoma, follicular, and mantle cell lymphoma. We also have a number of bispecific antibodies both on clinical trial, and we recently got our first FDA approval of a bispecific antibody for follicular lymphoma.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.